Good evening. I'm Todd Bauer, and I appreciate that chance to join you this evening remotely from Nashville, Tennessee. Dr. Martinez, thank you very much for that kind introduction. I'm excited to talk to you tonight about lorlatinib, a novel ALK-targeting therapy. What I want to do is talk about, first in general, the multiple targets we have in non-small cell lung cancer now. Then I want to dial in specifically to ALK and to lorlatinib and discuss with you how that is a different therapy than current ALK inhibitors. And then I want to talk to you about the unique side effects of lorlatinib and how you can manage those safely and effectively in your patients. So the current NCCN guidelines for testing in non-small cell lung cancer are pretty overwhelming. It's not EGFR and ALK and ROS anymore, but also BRAF and NTRK and the MET exon 14 skipping mutation, RET, and of course PD-L1. This is a lot of different testing, and how do you make sense of this in the world? Well, if you have access to broad-based next-generation sequencing, that's ideal because you can order one test and get all these results back from that. But if we don't have NGS, what do? Well, play the odds. So we know EGFR is the most likely to be present, so we test that first. And then you get down into the others that become 5 and 3 and 2 and less than 1%. And so you sequence them in that manner. You can use FISH, IHC, or even qPCR to try and test for these. Some of them don't test well for IHC. For instance, RET is not well discovered by IHC, so that really needs to be done through FISH or for PCR. Now, good news, bad news. Good news for our patients, we are going to continue to find more of these targets and have more specific treatment options for them. Bad news for us is trying to keep up with them, so it's only going to be more complicated as we go forward. What I can say is I'm going to simplify ALK for you today and help you to understand the treatment landscape in ALK-positive lung cancer. Going back to crizotinib in August of 2011, there's been a lot of changes, especially over the past 2 to 3 years. Really, the introduction of alectinib and brigatinib changed the landscape and how we think about the right sequencing of these drugs for our patients. Lorlatinib, of course, and the other follow-on drugs are still coming out as well. So we're going to talk about how we would use those. How do we make them better, and why does it matter to use a newer drug? Well, if we can increase potency and selectivity against the therapeutic target, we can treat it better. If we can optimize the drug properties based on a biological understanding of the disease, such that we treat patients with brain metastases more effectively, that's good for patients. And if we can figure out why these cancers become resistant to earlier lines of ALK inhibitors, we can leverage that knowledge to treat the patients more effectively. So we see here just a few different tyrosine kinase inhibitors, lorlatinib being a third-generation ALK TKI because of its cyclical structure. The others are non-cyclical, and this really gives lorlatinib a different set of properties. It also does have different side effects and does penetrate the blood-brain barrier quite well. When we looked at the second-generation ALK inhibitors in patients with crizotinib resistance, we see an improvement there. For patients with ceritinib, a 56% objective response rate, alectinib 50%, and brigatinib a 71% objective response rate in the first studies that were published on those. So we know that the second-generation drugs can better treat ALK inhibitors because they are more selective and have a more specified mechanism on the ALK tyrosine kinase inhibitor. So when we looked at transferring these into the first line, because if they work better in the second line, they're probably going to work better in the first line. We have all the first line studies that were published as of late last year, looking at crizotinib versus chemo and ceritinib versus chemo. The real difference that we see in this is when we start to compare the second generation TKIs head-to-head against crizotinib in the first lining. We saw objective response rates of 83% in alectinib versus crizotinib. Again, the updated results of 83%. Alectinib in the Alicia trial showing a 91% objective response rate, and then 92% in the J-ALEC study. So clearly, these drugs work very well in the first line setting too, and work better than crizotinib does. So that's why they are now used in the first generation setting. The hard question is, what do we do when they progress on those? Well, that's where lorlatinib comes in, as it's currently approved in Argentina. It comes in as a third generation TKI, really a second line treatment, and there's a lot of hope for our patients in that. The global registration study was designed as patients who'd had either had an ECOG of 0 or 2, had brain metastases either treated or untreated, and they were ALK positive. These patients were started on Lorviqua, 100 milligrams orally daily in continuous 21-day cycles. It was a pretty complex study, but it was broken down so we could really see where lorlatinib would fit into the treatment timeline. So expansion 3B was patients who'd had at least one prior second generation ALK TKI and chemotherapy. Expansion 4 was 2 prior ALK TKIs plus or minus chemotherapy. And expansion 5 was 3 prior ALK TKIs and chemotherapy, looking for overall response rates and intracranial response rates. Keeping in mind that all of these patients had had multiple prior TKIs, we see a really impressive response rate with this waterfall plot, including some complete responses. So this is from expansion 4 or 5. So all of these patients had had at least one prior second generation TKI and could have had 2 prior second generation TKIs. For those patients who just had one prior TKI in the purple waterfall plot, we see complete response in one patient and a really nice response curve as well in these patients. So this to say that whether it's after 1, 2, or even 3 prior ALK tyrosine kinase inhibitors, lorlatinib can be highly effective for these patients. I'm going to share a couple of my patients with you who I've treated for over 4 years on lorlatinib to help drive these points home. We'll also talk about some of the side effects through these cases as well. So Matt was a 24-year-old MD PhD student when he was admitted for evaluation of pneumonia. He was actually found to have a pericardial effusion, went into tamponade, and had to and suffered a cardiac arrest and a bedside pericardiocentesis. It was found to be a malignant effusion, and he got 1 dose of cisplatin, Alimta, and erlotinib prior to his EML4 ALK fusion coming back positive. His next treatment was started on crizotinib just a day or 2 after the test returned positive. And he was on crizotinib for about 8 months before, unfortunately, he progressed. He then went on a clinical trial of ceritinib and again got 6 months out of that before progressing on clinical disease. Over the next few years, you'll see that he went back and forth between chemotherapy and bevacizumab, different therapies. I met him in the spring of 2015 and began treatment on lorlatinib on April 15th, 2015. This CT scan is Matt. This is March 26, and you look at the left axilla, you don't see any evidence of adenopathy. Just about 3 weeks later, he had significant adenopathy in the left axilla. This is right before he started. He was really unable to lift his left arm up above his shoulder because he was in so much pain. He was started on lorlatinib, and over the next week or 2, he said it started to feel better. Just 6 weeks later, we saw a near complete resolution of that adenopathy. In less than 3 months later, we saw a complete response in the left axilla. It's great. Every 3 months, I get an email from his mom that just says, "Scan still clear, praise God." And truly, indeed, this treatment has worked very well for him. His side effects have really been limited to a little bit of slow augmentation, but having said that, he was able to complete his PhD and now works in industry, helping develop drugs for other patients like himself. Brad, another patient of mine, was 39 years old when he developed a cough lasting at least about 6 months. His wife finally convinced him to go get a chest x-ray, and he was found to have a left hilar mass and diffuse adenopathy. It was confirmed to be lung cancer, and he did wait to start treatment until his profiling came back and showed an EML4 ALK translocation. So he initiated first-line crizotinib in June of 2013. About 8 months later, though, he developed some headaches and was found to have numerous CNS metastases. He was started on whole brain radiotherapy in February 2014, and then transferred to me to look for a clinical trial, and I put him on the lorlatinib phase 1 trial on April 15th, 2014, a year before Matt. We know that ALK-positive lung cancer often goes to the brain, more so than we see in other types of molecular-driven tumors. And even if they don't have brain metastases present at diagnosis, by about 3 years, over half of patients will. So it's a problem with ALK-positive lung cancer. Well, other second-generation ALK inhibitors do have some good activity in the brain. Alectinib, a 64% objective response rate in the brain. Brigatinib, depending on the study, anywhere from 46 to 67%. So those drugs also do work well in the brain. What's pretty incredible is when you look at these patients with CNS activity after multiple prior TKIs, we know that the cyclical structure of lorlatinib and its brain penetrance is even greater than those second generation TKIs, which have great effect in the post-crizotinib setting. So what we've seen is as we've developed better drugs with better selectivity and better biology, they're more effective and they work even where the quote unquote good drugs as of 2 or 3 years ago stop working. The other cool thing about lorlatinib is it does appear to have a brain protective effect. There's a lot on this slide, so I want to walk you through it. In that expansion 3B and 4, the intracranial response rate was 46% and 48% in those different groups. The median duration was not reached in 15 months in the expansion 4 and 5 groups. Now, in those patients who had baseline metastases at present, they were much more likely to progress below the shoulders and visceral locations than they were in the brain. In fact, the probability of non-CNS progression was 35% at 12 months versus just 23% in CNS progression. And in patients who did not have brain metastases present at diagnosis, the likelihood, the probability of non-CNS progression was 55% versus just 12% in the brain. So clearly lorlatinib can treat disease well in the brain and does appear to have this protective effect, which is life-altering for our patients. So remember, Brad was started on lorlatinib in April of 2014. He did well with this, did have some dose reductions for some slowed mentation, and he actually had seizures in November of 2018. No structural problems were found. We didn't see any metastases. And I did give him a drug holiday. And after about a week, everything cleared up and he was back to his baseline. He did resume treatment in December 6th at 50 milligrams, and he continues on a near CR now 2 years after that. So he's been on this drug for 6 years, going on 7. He's had some toxicity from it in the brain, which is one of the big concerns with the drug, and I understand that. But he's been able to dose reduce and live a pretty normal life despite that. So I do want to talk about the CNS effects because there's a lot out there about this. The ALK positive lung cancer group is one of the most proactive and well-educated group of patients I've come across. They talk on Facebook and on message boards, and they really, really are connected. And when lorlatinib came out, it had a very few patients on the study. And so there was some magnification of some of the side effects. And CNS effects, I think, has kind of gotten out there as a horrible, intolerable thing for patients on this drug. And there's some concerns, no question, but I want to make sure it's kept in perspective. So the major CNS effects really include changes in cognitive function, mood, and speech. Most of these are mild in severity, intermittent, and improved or resolve upon dose modification. These adverse drug events were repeated frequency of 39.7%, with 12% experiencing at least one of them. So they might, or more than one of them. They might have had some slowed cognition and some depression. Now, keeping in mind, in this patient population in the phase 1/2 study, 71 or 72% of the patients had brain metastases present. A lot of them had brain radiation. And as I think through it, for instance, my patient Brad, I don't have any other patients that had whole brain radiation 5 years ago to know what that looks like. So I do think that a lot of what we saw, that there are other considerations for what may be contributing to the cognition issues they were having. Now, 24 patients did require dose modifications due to the CNS effects. 15 of those patients had complete resolution of the CNS effects and were able to continue at one dose level lower. The median time to resolution was about 12.5 days, and that's resolution to baseline. You started to see improvement in those symptoms after about a week. And reoccurrence of CNS effects upon rechallenge at the same dose and reduced dose occurred in 6 and 7 patients respectively. So the reassuring thing to me is that if we have to dose reduce, these CNS effects do resolve. And if they do occur upon reintroduction of the drug, we can hold the drug again and they do resolve. And we know that a dose level of even 50 milligrams of lorlatinib, half of the starting dose, can be an effective dose for these patients, and in most cases will be. I could get into the pharmacokinetics of why that's important and why we went to 100 milligrams as a recommended dose. But to suffice it to say that most patients will continue to respond at these reductions at 75 and 50 milligrams. So again, for mild adverse events, you would continue at the dose or withhold until they resolve and re-challenge at that same dose. But when they get to moderate and severe, we do need to hold the drug until they resolve down to their baseline and re-challenge at one dose level lower. If these become life-threatening or grade 4 toxicity, the official recommendation, of course, is to permanently discontinue lorlatinib. I always talk with patients and caregivers about starting on lorlatinib to pay very close attention to any change in mood and signs of depression, slowed cognition, or even hallucinations to help us keep an eye out for these and stop the drug quickly if we start to see them. Now, being a third generation drug, it is a different drug and it has different side effects. The CNS effects are certainly the most talked about, but the most common thing we see are elevations in lipids and triglycerides. I had a patient who is a retina surgeon who told me he didn't think he was going to have problems with his cholesterol because he was so active and fit. And indeed, he very much was. However, his cholesterol got to level of 550 or 600 before he allowed me to start a statin. I started him on Crestor, rosuvastatin. His cholesterol dropped down to 200 within a week or two. So the therapies for these are very effective. And for hypercholesterolemia, my recommendation is to treat it just like we all treat hypothyroidism in patients on checkpoint inhibitors. If we start to see changes in TSH, we don't stop the drug, we just start them on Synthroid. Same is true for patients on lorlatinib with their cholesterol. If we start to see the cholesterol go up, or rather when we start to see the cholesterol go up, we just institute statin therapy and go on and continue on. Now, I will say which statin is very important because of CYP3/4A interactions. So rosuvastatin is my go-to in patients with who are on treatment with lorlatinib. One thing that I want to make a solid point of stating is, while there were temporary dose reductions in 22% and 20% with interruptions and reductions, the incidence of permanent discontinuation due to adverse reaction was only 2%. So there is much discussion about this drug being difficult from a mental status standpoint or from an edema standpoint or cholesterol standpoint. And though those side effects are real and we have to watch out for them, if we're only having to stop 2% of patients due to those side effects, that means the drug and the side effects it causes can be well managed in the vast majority of our patients. So I'd encourage you to pay attention to the data as we look at this drug going forward. Again, for the hyperlipidemia, I do tell people they're just going to assume to start rosuvastatin. And when they do hit a cholesterol level of over 200, I go ahead and start them on rosuvastatin and continue it. And I've not been able to control hypercholesterolemia with that mechanism if needed. Fenofibrate, if the triglycerides don't come down through rosuvastatin, is the correct addition there as well. Guys, that is all I have for you today. I really appreciate your attention to this. I look forward to the question and answer session and wish you luck in taking care of your patients with ALK-positive lung cancer. Thank you very much and enjoy the rest of the meeting.